તો આપણને એવું થાય કે કંઈક ઘણું ખાઈએ. તો એ જ રીતે આપણા પ્રેસિડેન્ટ ડૉક્ટર મેહુલભાઈ શેલતે 2 ટાઈપના લેક્ચર્સ તમારા પ્રી કોન્ફરન્સ માટે તમને પીરસ્યા છે. One is an academic lecture and it is a lecture to be given by a very well-known joint replacement surgeon and orthopedic surgeon, Dr. Ateet Sharma. We welcome you, sir, here at our pre-conference. And after this nice, very interesting academic lecture, we have one very interesting non-academic lecture, and that is by a motivation speaker જેનું નામ તમે બધાએ સાંભળ્યું હશે અને જે લોકોને યુટ્યુબ જોવાની ટેવ હશે તો એમને સાંભળ્યા પણ હશે. અને this lecture is being given by Mr. Sanjay Raval. તો આજે આટલા સુંદર આપણી પાસે એક એકેડેમિક ફીસ્ટ છે, એક નોન એકેડેમિક ફીસ્ટ. So I hope you all will enjoy this pre-conference event. I now welcome our President, Dr. Mehulbhai Shelat, to welcome you all at this pre-conference event.
મેં તો તમને દેશો ને બહુ ટાઈમ બગાડવો નથી. અતીતભાઈ જોડેથી ઘણું બધું શીખવું છે, ખાલી માત્ર 20 મિનિટમાં. અને પછી સંજયભાઈ સાથેથી ટેન્શને ટાટા અને બિગને બાય બાય કરવું છે. આપ સૌને નો ખૂબ ખૂબ આભાર અને વેલકમ યુ ઓલ. થેન્ક યુ.
Thank you, Dr. Mehulbhai, for being so sharp. And now I welcome and invite Dr. Atulbhai Gandhi, who is an anesthesiologist, especially a pediatric anesthesiologist, a very well-known one, to introduce our today's speaker, Dr. Ateet Sharma.
Thank you, Mona ma'am. Dr. Ateet Sharma is doing MBBS and MS Ortho from Bijay Medical College, Civil Hospital. He done recent advances in knee joint and division knee joint replacement surgery from fellowship from Bangkok, USA and Singapore. He done basically special interest in shoulder surgeries, shoulder replacement, hip replacement, and also the revision replacement surgeries. Really is a master of this revision replacement surgery, because of the nowadays knee replacement is done everywhere. But after 10 to 15 years, there may be a chance of revision. So then now is an era for revision surgery. So he is a really special interest in revision knee surgeries. I am welcome to Dr. Ateet Sharma for giving recent advances for the knee replacement. Thank you.
For this recent advances in knee replacement lecture. So I would be talking about recent advances in knee replacement. So I'm sure everybody present here would be knowing everything about total knee replacement. So we will just brush up our knowledge with about 4 slides about knee replacement. Only 4 slides for the knee replacement, and then we would go to a more exciting and a relatively new topic, which is unicondylar knee replacement. Okay, knee replacement, is there anything new? So the commonest form of arthritis is primary, which is due to aging. Out of the 10 patients we operate, 8 are of primary osteoarthritis and only 2 are of rheumatoid arthritis or gouty arthritis. Arthritis affects mainly the knee and less commonly the hip, in the ratio of about 80 to 20%. So predisposing factors are age more than 60 years. It is more common in females, 7:3, hereditary from our parents. BMI, if it is high, then trauma to the knee is more, and then arthritis sets in early. Injury, if there is any injury while playing or while doing your work, and sometimes occupation which needs you to sit down, go upstairs, and these kind of things can have more arthritic chances. So the treatment options are, first of all, conservative, in which we can give analgesics and physiotherapy and sometimes braces. Arthroscopic debridement is just to be written here but not done now. High tibial osteotomy, a school of thought. And the final answer of the gold standard is total knee replacement, which was a gold standard till about 5-6 years ago when we started doing unicondylar knee replacement. There was one thing which was not known to most of the patients and their family members was the cost of the implant, which was kept top secret by the doctors as well as the implant companies, which has become an open secret now because of the NPPA, the cost. So the designs in this are commonly the three: all poly, metal back and rotating platform. So this is the all poly joint. The tibia is of polyethylene and femur is of chromium cobalt, and the X-ray looks like this. The tibia, you can see only the all poly like this on the X-ray. The metal back, it has three components: the femur, the tibia and the poly in between. So the X-ray looks like this. The space in between is the poly, and in this the poly is fixed, so it's called a fixed bearing, while the last is the rotating platform, in which the poly rotates about 10 to 15 degrees on the tibial platform, and they say that the wear rate is less in rotating platform knees for younger patients. And this is the X-ray. So this was about total knee replacement, which almost all of us would be knowing here. Now still something remains to be known, and it is unicondylar knee replacement. So anybody heard about unicondylar knee replacement or partial knee replacement, microplasty? Anybody here? No? Okay. So just to give you a brief discussion, arthritis almost always starts from the medial condyle of femoral-tibial joint. If nothing is done at this stage, then it will progress to patellofemoral and the lateral condyle, and then it will become a global osteoarthritis. So there are so many X-rays which we see during our routine practice, in which only the medial side of the joint is damaged. The lateral side is almost intact. Another X-ray, the medial side is damaged, lateral is good. Here also the medial side damaged, lateral is good. Even if in the late form of arthritis, you can still see the lateral joint space is good while the medial only is gone. So in case of patients who come to us a bit early or who have only medial joint arthritis, we can offer them a unicondylar knee replacement, which is replacement of only the medial condyle of the femur and tibia with the poly in between. The lateral condyle is left intact, plus the ACL and the PCL, all the ligaments are left intact. Unicondylar knee is not possible in medial and patellofemoral OA or in global OA. For them, we have to go for total knee replacement. So the concept behind is that if you have a small part of the apple which is bad, you don't need to remove the whole peel. You can remove only the part and save up to 75%. So only the damaged compartment is replaced. See, only the medial compartment, the X-ray is like this, while in a total knee, you are changing the whole. In total knee, you have to cut at least the anterior cruciate ligament. Many are preserving the PCL, but an ACL has to be cut in that. While in case of UKR, we can save both the ACL and the PCL. So this is the unicondylar, only resurfacing the femur tibia. The incision is almost half of the knee replacement, and while this is the knee replacement which we know. In this, the incision being small, we cut only the retinoculum and go into the vastus medialis muscle. We are not cutting any part of the tendon, and no ligaments are cut in that. You can see the anterior cruciate which is here is not cut in a unicondylar. So 75% of your normal bone is preserved, which may be useful to you in the later on life when a revision is required, and only 2 to 3 days of hospital stay is required. So what are the advantages? There is less bone loss, less pain because of the lesser incision and no muscles cut, less blood loss, 2 to 3 days of hospital stay as compared to 4 or 5 days in a knee replacement. No physiotherapy is required because the knee is almost normal, the lateral condyle as well as the ACL. Less expensive, not in the cost form, because the cost of the implant is almost same as the knee replacement, but because you can go back to work early, and so it is less expensive. So in case of a UKR, less is more. It gives a more natural feeling because we have one part of 75% of the knee which is intact. It is more safe, I'll tell you why. More movements, more preserved biomechanics, more flexibility, stability and more satisfaction. we started doing unicondylar in 2013, and almost none of the patients want to come for a follow-up after a UKR because they don't have any problem. So 2 plus 2 is equal to 5 in this case. How it is done? A small incision on the medial side of the knee. This is the small part of the tibia which is cut. These are the implants, and this is a unicondylar. We need to cement these implants to the femur and tibia, just like we do in a TKR. So this is the post-operative X-ray. Only one part changed, the other part is intact. While in TKR, you need to change the whole. So the question which comes to the mind is whether this is a stopgap surgery. We are doing it for a period of 5-6 years. The data says that it is a 98% survivorship at 10 years and 91% at 20 years, which is the same survivorship for a total knee replacement. It's 91% at 20 years. Usage, they say that if you are going to do 4 UKRs in a year, then it's better you don't do it, because you will have less experience and the chances of failure would be more. More than 12 UKRs a year, then only you start doing UKRs, or you refer the patients to those centers who are doing more than 12 UKRs a year. The safety, if 100 patients receive UK instead of TKR, instead, the result would be 1 less death in the first 4 years of surgery. So it's a big number that there would be 1 less mortality if we are doing 100 UK instead of TKR. The ease of revision, if you have gone for a knee replacement and it has to be revised after 18 to 20 years, then the amount of implant you have to put inside the joint is this much. You need a sleeve, you need a rod. But if you have to change a UKR to a TKR, you can just go for a primary knee replacement. So this is not a replacement, this is a resurfacing. So there are some things which we need to know. What is the age criteria for UKR? The minimum age which we have operated is 42 years and the oldest patient was 85 years. So in case of the 42-year-old patient, it was the first surgery before he or she goes in for a revision replacement after 18 to 20 years. While for patients who are 65-70, it is the final surgery for their life, a unicondylar knee. What activities can be pursued after UKR? Cross-legged sitting is allowed. Cycling and swimming can be done. There are some patients who also play badminton, but I advise them that you play in doubles. Do not play singles, otherwise it would put more strain on the knee. Almost every patient whom I explain a UKR asks me this: what happens to the normal lateral joint after UKR? So, in this, the medial side of the joint is damaged. Supposedly we don't do anything at this stage. This joint will subluxate slightly on the medial, and then the lateral joint line also will get affected. So it will become a global OA. But if the patient comes on time and we do a unicondylar knee, then the knee is balanced, the lateral side is offloaded, and the lateral side does not degenerate after this. It becomes as good as normal. So, no extensive investigations required. No blood transfusion if the hemoglobin level pre-op is 10 or 11. Less than an hour of surgery, average is 35 minutes. Bilateral can be done easily because you don't interfere with the canal in this, and the chances of fat embolism are very less. 2 to 3 days of hospital stay. No home physiotherapy. Whatever physiotherapy has been done at the hospital and taught has to be done by you. And it is not for some time, as I told you, it's forever. So this is one of my patients with a 12-year follow-up. You see a unicondylar knee which was at that time available. She is still going strong. This was another patient who sent me a WhatsApp. She completed a 5mm motif charity walk. Sorry. So this was a 40-year-old patient whom we did a bilateral So she is still in the hospital and walking without support. And this was a picture which she sent to me afterwards. This one. Okay. So This is a 70-year-old male with a bilateral UKR and walking without support, still in the hospital. This 3 months post surgery, a 65-year-old lady walking comfortably. She was pretty heavy, BMI was around 35. This is a 1 month post-op which we did recently and walking comfortably. She was a 45-year-old lady and walking well. She had come for the stitch removal on this day and still she is able to walk well. So, what are the things to be known? You should be in time. Do not neglect your knee pain. The answer to all the knee pain is not a knee replacement surgery. There are other options also available. Know your options. That is, know before you go to the doctor what options do you have before you go in for the surgery. Save your bone, secure your future, and pay less and get more out of it. Thank you so much for your attention. And if you have any questions?
Any questions? We can entertain one or two questions. Yes.
Because I was in the district part. TKR has been added in Ayushman government, but it is not added in other part. What you said,
You can. Yes.
So that it should be added so that people will get
The benefit. Yes, it's required.
So initially partial this UKR which you say was being advocated for 12 or 15 years. Then in between there was a phase when all the orthopedic surgeons said that don't go for it.
Yes.
And now again it is advocated. Why so?
Yes, because it was advocated in somewhere around 2004 and 5, but the criteria for the surgery were not clearly defined. At that time, they were doing it in patients who had an absent ACL. They did not have an ACL. Now the criteria says that you need to have an intact ACL before you go in for a UKR, and that is why the survivorship has increased. Yeah.
So now the things are much clearer.
Yes.
Anyone else?
You argue about 70 and 80 years age of disability. So what is specifically this TKR is a one-time solution.
So this is also one-time solution.
But they last up to the 10 years, 15 years.
No, I showed you the survivorship data. So it's 91% at 20 years, which is the same for TKR. Which is the same for TKR.
I just see that's right.
Yes. So the survivorship is same as TKR. It's not a stopgap surgery that you do it and after 5 years you revise to a TKR. It's not like that.
What about the high tibial osteotomy?
High tibial osteotomy is a second school of thought. I don't go for high tibial osteotomy. Yes.
The cost can tell us.
The cost is the same as per the NPPA. The cost of this implant is 55,000, which is also for a metal back knee replacement. So the cost remains the same. Only thing that you go back to work early. There is no physiotherapy at home. So that is why it is a bit recovery period is faster.
Thank you so much, Dr. Ateet. I request Dr. Ateet to present